Every morning in medicine rooms and pharmacies across the developed world, adults over 60 open pill organizers containing 5, 6, 7, sometimes 10 or more medications, each of them prescribed by a thoughtful clinician for a specific indication, each of them tested for safety within an approved dose range, each of them supported by evidence that it reduces a specific risk in a specific population. And they take them all, and in the vast majority of cases, each individual medication is being taken correctly. But the question that rarely gets asked and that I want to explore today is not whether any single medication is appropriate. It is whether the collection, the combination running simultaneously through the same aging metabolism, the same partially impaired kidney and liver function, the same cardiovascular system, and the same nutritional balance, is being reviewed with the same level of rigor as each individual prescription was evaluated when it was originally written. Because the interactions between medications, particularly in adults over 60, whose drug metabolism is slowed, and whose accumulation of prescriptions has happened through multiple specialties over multiple years, with no single person looking at the whole picture, can produce cardiovascular effects that no individual prescription would produce on its own. These are not rare adverse events. They are documented pharmacological phenomena that, when the right combinations are present in the same person, produce measurable consequences for blood pressure, heart rhythm, electrolyte balance, and coronary risk that the person experiencing them almost never connects to their medication list. Before anything else, what I share in this video is educational information only. It is not medical advice. Do not stop or change any medication without speaking directly to your prescribing doctor. The interactions I am going to describe are reasons to have a specific, informed conversation with your healthcare provider, not reasons to make independent decisions about a regimen that may be carefully managed for reasons that are not visible from the outside. What I want to give you today is the knowledge to prompt that conversation productively. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. We have already discussed in a previous video on this channel how individual medications, including statins, NSAIDs, PPIs, and psychotropic drugs, can each carry specific cardiovascular risks and nutrient depletion effects. Today I want to go deeper into the combination problem. What happens when several of these medications run together, and how the sum can be more concerning than any of the individual parts. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60. And this is a video I have wanted to make for a long time because the polypharmacy cardiovascular interaction problem is one of the most consistently underaddressed topics in the care of older adults. Let me begin with the overarching pharmacological principle that makes combinations more dangerous than individuals in adults over 60, because without this foundation, the specific interactions I am going to describe cannot be properly understood. Drug metabolism in the body is carried out primarily by a family of enzymes in the liver, called cytochrome P450, or CYP, enzymes. These enzymes break down the majority of medications that enter the body, converting them into forms that can be excreted by the kidneys or the bile. Different drugs are metabolized by different CYP enzymes, and some drugs are not only metabolized by these enzymes, but also inhibit or induce them, meaning they change how quickly or slowly those enzymes process other drugs that share the same metabolic pathway. When a drug that inhibits a CYP enzyme is added to a regimen that already contains a drug metabolized by that enzyme, the concentration of the second drug in the blood rises because its breakdown has been slowed. It accumulates. Its effects are amplified beyond what the prescribing dose intended. And those amplified effects may include cardiovascular effects that were not present at the intended dose. In adults over 60, where the CYP enzyme activity is already reduced by 20 to 40% compared to younger adults, this interaction is not a theoretical concern. It is the pharmacological reality of a system that cannot process multiple drugs with competing enzyme demands as efficiently as the studies that established each drug's safety profile assumed. Added to this is the issue of the QT interval, the electrical recovery phase of the cardiac cycle that we discussed in our medications and heart video. A large number of commonly prescribed medications prolong this recovery phase to some degree. Each one individually, within its approved dose range, produces a prolongation that is generally considered safe. But when 2, 3, or more QT prolonging medications are present simultaneously, in an older adult whose cardiac electrical reserve is reduced by age and underlying disease. The combined prolongation can reach the threshold at which life-threatening arrhythmias become a genuine risk. These two mechanisms, the CYP enzyme interaction and the additive QT prolongation, are the primary pharmacological engines behind the combination cardiovascular risks I am about to describe. The first dangerous combination involves calcium channel blockers, specifically verapamil and diltiazem, combined with statins, specifically simvastatin and lovastatin. Verapamil and diltiazem are prescribed for blood pressure, for atrial fibrillation rate control, and for angina. They are effective and commonly prescribed. They are also potent inhibitors of the CYP3A4 enzyme, one of the liver's primary drug metabolizing enzymes. Simvastatin and lovastatin are both metabolized almost exclusively by CYP3A4. When verapamil or diltiazem is added to a regimen containing either of these statins, the CYP3A4 inhibition from the calcium channel blocker reduces the metabolism of the statin. The statin's blood concentration rises, sometimes to 2 to 5 times the expected level. And at these elevated concentrations, the muscle toxicity risk of the statin, specifically the risk of statin-associated myopathy, and the rare but serious condition of rhabdomyolysis, the breakdown of muscle tissue that can cause acute kidney injury, increases substantially. For the heart specifically, the elevated statin concentration in the context of CYP3A4 inhibition also amplifies the CoQ10 depletion effect we discussed in our previous medications video. CoQ10 depletion at elevated statin concentrations is more pronounced, and the cardiac energy production impairment from CoQ10 deficiency becomes more significant. The practical management of this interaction is well established in clinical pharmacology. When a calcium channel blocker of the diltiazem or verapamil type is necessary alongside a statin, the appropriate statin choice is one that is not primarily metabolized by CYP3A4, specifically rosuvastatin, pravastatin, or fluvastatin. These statins do not accumulate in the presence of CYP3A4 inhibition because they use different metabolic pathways. But this substitution only happens if someone is looking at the complete medication list with knowledge of which drugs compete for which enzyme. The prescribing cardiologist who added diltiazem may not have reviewed the statin that the lipid specialist prescribed 5 years earlier. The pharmacist automated system may not flag the interaction at standard doses, and the patient is between two specialists who are each managing one condition, and neither is looking at the whole. Type in the comments right now if you take both a calcium channel blocker and a statin, and have never been told specifically which statin is appropriate in that combination. Because I suspect many people watching this video are in exactly that situation. The second combination involves the NSAIDs, the non-steroidal anti-inflammatory drugs we discussed in our previous medications video, and ACE inhibitors, or ARBs, the blood pressure medications that work through the renin-angiotensin system. ACE inhibitors and ARBs are among the most evidence-backed medications in all of cardiovascular medicine. They reduce blood pressure, protect the kidneys in diabetes, reduce cardiac remodeling after heart failure, and lower mortality in high-risk cardiovascular populations. They are appropriately and widely prescribed. NSAIDs, as we discussed, inhibit the prostaglandins that maintain the vasodilation of the afferent arteriole, supplying the kidney's filtering units. This is the mechanism by which regular NSAID use raises blood pressure. But when an ACE inhibitor or ARB is also present, an additional and more serious interaction occurs. ACE inhibitors and ARBs work partly by dilating the efferent arteriole, the outflow vessel from the glomerulus which maintains the filtration pressure gradient. NSAIDs constrict the afferent arteriole, the inflow vessel. When both drugs are present simultaneously, the afferent arteriole is constricted and the efferent arteriole is dilated. This double hit on the filtration pressure gradient can reduce the glomerular filtration rate dramatically, producing acute kidney injury that is sometimes reversible if the combination is identified and stopped, and sometimes not if it has been running for months and the damage has accumulated. This combination is so reliably nephrotoxic that it has been given a name in the pharmacology literature, the triple whammy combination, when a diuretic is also present alongside the ACE inhibitor, or ARB, and the NSAID. All three together reduce renal blood flow from 3 different directions simultaneously, and the acute kidney injury risk in an older adult on this combination who becomes even mildly dehydrated is substantial. A study published in the British Medical Journal found that adults on the triple whammy combination, an ACE inhibitor or ARB, plus a diuretic, plus an NSAID, had a significantly higher rate of acute kidney injury and associated cardiovascular events compared to those on any two of the three drugs, without the third. The kidney injury that follows this combination reduces cardiac output through multiple mechanisms and directly increases the risk of subsequent cardiovascular events. The practical implication is that any adult on an ACE inhibitor or ARB who is also taking any NSAID, including over-the-counter ibuprofen or naproxen, is carrying this interaction. The NSAID does not need to be prescribed. It needs to be present, and it will not be flagged in a medical record as a drug interaction if it is an over-the-counter purchase that no prescribing physician knows about. And share this video right now with one person in your life over 60 who takes a blood pressure medication and also reaches for ibuprofen for pain management, because the combination they consider unremarkable has a specific, documented, clinically significant impact on the kidney and the cardiovascular system that they deserve to know about. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about a patient I will call Barbara, 67 years old, retired nurse from Cleveland, Ohio. She had hypertension managed with an ACE inhibitor and a diuretic for 8 years. She had started taking ibuprofen approximately 2 years prior for knee pain, over the counter, reliably, 4 to 5 times per week. When she came to me, she reported fatigue and reduced exercise tolerance that had developed gradually over the preceding 18 months. Her blood pressure, which had been well controlled, had required 2 upward adjustments of her medication over the same period. Her most recent creatinine, taken 6 months prior, had been at the upper limit of normal for the laboratory. He ran a creatinine and a full metabolic panel. Her eGFR was 41. She had lost approximately 30% of her kidney function from a level that had been normal 2 years before. The timeline coincided almost precisely with the beginning of her regular ibuprofen use. Her ACE inhibitor, her diuretic, and her ibuprofen had been running as the triple whammy combination for 2 years, and her kidneys had been quietly losing their filtration capacity under the combined pressure of all three. The ibuprofen was stopped and replaced with acetaminophen, and a topical diclofenac gel for the knee. Her eGFR partially recovered over the following 6 months to 58, a meaningful improvement. It did not fully return to normal because some of the damage was structural. Barbara told me I was a nurse. I should have known better. I told her, "You knew everything about NSAIDs from a textbook. What nobody told you was which combination in your specific medication regimen made the one you were taking dangerous." The third combination involves digoxin, a cardiac glycoside used for heart failure and for atrial fibrillation rate control, combined with several medications that affect its levels through various mechanisms. Digoxin has one of the narrowest therapeutic windows of any commonly prescribed drug, meaning the difference between a therapeutic dose and a toxic dose is small. At therapeutic levels, digoxin slows the heart rate, reduces electrical conduction through the AV node, and increases the contractility of the heart muscle. At toxic levels, digoxin produces nausea, visual disturbances, and potentially lethal cardiac arrhythmias, including complete heart block and ventricular fibrillation. Digoxin toxicity risk is dramatically increased by hypokalemia, low potassium in the blood. The mechanism is specific. Digoxin works by inhibiting the sodium-potassium ATPase pump in the cardiac cell membrane. When potassium is low, digoxin's inhibition of this pump becomes more pronounced at the same blood concentration, pushing the drug's effect from therapeutic to toxic without any change in dose. Thiazide diuretics, among the most commonly prescribed blood pressure medications in adults over 60, increase urinary potassium excretion. Loop diuretics used for heart failure do so even more aggressively. An adult on digoxin who is also on a diuretic is in a situation where the diuretic is continuously driving the potassium lower, and the lower potassium is continuously increasing the effective cardiac potency of the digoxin, moving the therapeutic window in a direction that the original dose never anticipated. In adults over 60, where kidney function is reduced and digoxin clearance is already slower than in younger adults, the potassium depletion from diuretics can push digoxin from a well-managed therapeutic level into toxicity without any change in the prescribed digoxin dose and without any level of digoxin in the blood that would appear overtly toxic on a single measurement. A study published in the Journal of the American College of Cardiology found that hypokalemia in adults taking digoxin was associated with a significantly higher rate of digoxin-related adverse cardiac events, and that the combination of thiazide diuretics and digoxin without potassium monitoring was one of the most common settings in which digoxin toxicity presented in older adults. The interaction was preventable with regular potassium monitoring and potassium supplementation, where indicated. Any adult taking digoxin alongside any diuretic should have their potassium checked at regular intervals, specifically at least every 3 to 6 months, and the potassium level should be maintained comfortably above 4.0 millimoles per liter, rather than simply above the laboratory lower limit of normal. You want to briefly mention a second electrolyte cardiac drug interaction in this same section, because it follows the same mechanism and is equally common. The combination of diuretics with amiodarone, a powerful antiarrhythmic drug used for atrial fibrillation and certain ventricular arrhythmias. Amiodarone prolongs the QT interval as part of its mechanism. Diuretic-driven hypokalemia amplifies QT prolongation from any drug. The combination of amiodarone plus a potassium-depleting diuretic without careful electrolyte monitoring is a setting in which the Torsades risk is real and preventable. Adults on amiodarone should have electrolytes checked far more frequently than the standard annual metabolic panel, and any reduction in potassium or magnesium below optimal levels should be corrected promptly rather than simply noted. The question to bring to your prescribing physician is, given that I take both digoxin and a diuretic, how often is my potassium being checked? And is there a plan to maintain it at a level that provides adequate safety margin for my digoxin dose? If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because the depth of specific pharmacological knowledge I am bringing to this conversation is what this channel delivers every week, and it is the depth that makes these conversations with your doctor genuinely more effective. The fourth combination is the one that has the potential to affect the largest number of adults over 60, because it involves two of the most widely prescribed medication classes in this age group, and produces its cardiovascular effect through the additive QT prolongation mechanism I described at the start. Certain antidepressants, specifically citalopram, escitalopram, and to a lesser degree sertraline, combined with azithromycin, one of the most commonly prescribed antibiotics, or with fluoroquinolone antibiotics including ciprofloxacin and levofloxacin. Both SSRIs, particularly citalopram and escitalopram, and both azithromycin and fluoroquinolone antibiotics prolong the QT interval on the electrocardiogram. Individually, each within its approved dose range, the prolongation produced by any single drug is generally modest and considered acceptable. But when a short course of azithromycin or ciprofloxacin is prescribed for a respiratory or urinary tract infection in an adult who is already on a chronic SSRI prescription for depression, the combined QT prolongation from the two drugs simultaneously may exceed the threshold at which Torsades points. The potentially fatal ventricular arrhythmia we discussed in our medications and heart video becomes a clinically real risk. This interaction is particularly concerning because the antibiotic course is almost always prescribed by a different clinician from the one managing the antidepressant, and the prescription is frequently generated without a complete medication review. A patient calls their GP with a chest infection. They are prescribed azithromycin. The GP may or may not have access to the full medication list at the time of the telephone or online consultation. The QT prolonging interaction is not checked. A study published in the New England Journal of Medicine found that azithromycin use was associated with a significantly higher cardiovascular mortality rate than comparator antibiotics, and that the excess mortality was concentrated in patients with pre-existing cardiac risk factors, specifically those with higher baseline QT interval risk. The adult on a chronic SSRI is exactly in the category of higher QT risk at baseline. The question to ask whenever a new antibiotic or any new short-term medication is being prescribed is, given the medications I am already taking, does this new prescription have any QT prolonging effects that might interact with anything already on my list? This question is simple, it is specific, and it will often prompt the prescriber to either confirm there is no interaction or to consider an alternative antibiotic with a lower QT prolonging profile. The fifth combination addresses a slower, less dramatic, but equally important cardiovascular risk, the combination of PPIs, proton pump inhibitors, and diuretics, which together deplete magnesium through two different mechanisms, producing a state of chronic hypomagnesemia that directly impairs cardiac rhythm and vascular function. We discussed the magnesium depletion from PPIs extensively in our previous medications video. EPIs reduce magnesium absorption from the gut. Loop and thiazide diuretics increase magnesium excretion in the urine. When both a PPI and a diuretic are present simultaneously, which is extremely common in adults over 60 who have both acid reflux and hypertension, two independent pathways for magnesium depletion are operating simultaneously, and the combined depletion is significantly faster and more complete than either pathway alone. Hypomagnesemia, as we discussed, is a recognized cause of cardiac arrhythmias, including atrial fibrillation, through its effects on the stabilization of the cardiac cell membrane potential. The threshold for atrial fibrillation is lower in the presence of low magnesium, and the atrial fibrillation that occurs in a magnesium-depleted heart is often resistant to the usual pharmacological management until the magnesium deficit is corrected. Hypomagnesemia from this drug combination also impairs the function of the renin-angiotensin-aldosterone system in a way that makes blood pressure harder to control, contributes to insulin resistance through its role in insulin receptor signaling, and produces the non-specific symptoms of chronic low magnesium, specifically muscle cramps, fatigue, and difficulty sleeping, that are consistently attributed to aging rather than to the drug combination causing them. A study published in the American Journal of Medicine found that adults on long-term PPI therapy plus diuretics had a significantly higher rate of clinically significant hypomagnesemia than those on either class alone, and that a substantial proportion of cases were entirely asymptomatic until a cardiac arrhythmia presented as the first detectable clinical manifestation. The question to bring to your doctor if you are on both a PPI and a diuretic is, given that both of these medications affect magnesium balance, is my magnesium being measured regularly, and is the result being compared to the threshold required for adequate cardiac electrical function rather than simply to the laboratory lower limit of normal? Here is the complete framework for addressing the polypharmacy cardiovascular risk I have described. Bring your complete medication list to every appointment with every prescribing physician, including all over-the-counter products and supplements. The combination that is dangerous is almost never visible from any single prescription. It is only visible from the whole list. Ask specifically for an annual pharmacist-led medication review that assesses the whole regimen for interactions. This is a distinct service from checking whether individual prescriptions are within their approved dose ranges. A medication interaction review looks at what drugs are doing to each other. Many hospital systems and community pharmacies offer this service. It is almost never suggested proactively. Ask for it by name. Ask which medications on your list are metabolized by CYP3A4, and whether any of the other medications on the list inhibit or induce that enzyme. This question, asked specifically, forces a review of the pharmacokinetic interactions that are most commonly missed. Ask whether your current regimen contains any combination of QT prolonging medications, and whether an ECG assessing your baseline QT interval has been performed recently. Any adult over 60 on 2 or more medications with any QT prolonging potential deserves a baseline ECG that documents the QT interval before any future prescribing occurs. Ask whether your electrolytes, specifically potassium and magnesium, are being monitored at intervals appropriate to your specific diuretic and PPI combination, and whether the targets being used are the safety margins appropriate for your cardiac medications rather than simply the general laboratory reference ranges. Ask when any new medication is added, what does this new drug do to anything already on my list? This question requires a pharmacokinetic consideration at the moment of prescribing, rather than after a problem has developed, and it is the question most consistently absent from the prescribing conversation. A prescriber who cannot answer it with confidence should be prompted to check an interaction database before finalizing the prescription. Most electronic prescribing systems have this functionality. Most are only used when a dramatic red flag alert appears. The subtle but cumulative interactions I have described today do not trigger red flag alerts. They require active clinical thinking, prompted by a patient who knows to ask. 4 things to carry away. First, the cardiovascular risk from medications in adults over 60 is most often not in any single drug, but in the interaction between drugs being managed by different prescribers who are not communicating with each other and who are not looking at the same complete list. The risk is in the combination, and the combination requires someone who is simultaneously looking at everything. Second, the CYP enzyme interaction between calcium channel blockers of the verapamil and diltiazem type and CYP3A4 metabolized statins is one of the most clinically significant and most consistently unmanaged drug interactions in this age group. If you are on both, ask your physician whether you are on the appropriate statin for your specific calcium channel blocker. Third, the triple whammy combination of ACE inhibitor or ARB plus diuretic plus NSAID is a documented, named, and preventable cause of acute kidney injury and cardiovascular events in older adults. The NSAID component is often over-the-counter and invisible to the prescribing record. If you are on blood pressure medication and a diuretic, the over-the-counter pain medication you reach for matters clinically. Fourth, the additive QT prolongation from combining a chronic SSRI with a short-course antibiotic like azithromycin or a fluoroquinolone is an acute risk that arises from prescribing across different clinical contexts. Knowing that you take an SSRI and disclosing it specifically, when any new medication is prescribed, including antibiotics, is the simplest protection against this interaction. Your medication list is not a static record of individual treatments. It is a dynamic system in which every addition changes what every existing drug is doing. The clinician who reviews it as a system, looking for the interactions between elements rather than the safety of each element alone, is providing a genuinely different and more comprehensive service than the routine prescribing that produced each individual entry. You can prompt that review. You can ask for it. And the questions I have given you today are the specific questions that make that review happen. Share this video with one person in your life over 60 who takes 5 or more medications and has never had a single appointment specifically dedicated to reviewing how those medications interact with each other. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that makes your next medical conversation genuinely more complete than the last one. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.